Welcome everybody. Thank you for coming to this lecture. I would like to really explain to you that this topic is one of my favorite topics. We discuss about aesthetic rehabilitation and the use of veneers in obtaining this kind of result. So first of all, I would like to say, before starting to grind teeth or to bond restorations, we should really be able to understand your case that you have in front of you. It means we have to really follow some very basic principle. Aesthetic and functional principle in order to obtain the best result. So I believe that the most important step is that to achieve this kind of result is to really have the data collection. We have to collect data. That's very important in order to be able to formulate the best treatment plan. And of course, that is happen thanks to many steps. For example, reading the book that I wrote on 204, the first volume, and 207, the second volume, we have the chance to obtain this kind of result. It means that we have the chance to have some charts, the traditional way, of course, where you can put all the parameters, judge all the parameters in order to say that is good, that is not good. And together with that, we have the chance also to combine all the aesthetic parameters and the functional parameters. In this way, you have the combination of both, and you can really be happy to understand the case. You can really catch the case and having the case in your hands. So today, of course, we have new stuff and new tools that can help us in achieving the best result. I mean that we can, obtain very important steps, very important data also through the digital tools. It means like the GetUp, guided study treatment that we have developed a few years ago, and that help the practitioner very much in order to obtain the best treatment plan formulation. That is very important because we start to in some way analyze all these steps and to analyze many things. It means that is represent an easy tool that can help the clinician and the practitioner to obtain the best treatment plan formulation. That is very important, together with the effective communication with the lab. The lab receives, maybe for the first time, all the information they need to build up the best kind of work in that have to send to you. Together with that is an effective way to communicate with the orthodontist, with the endodontist, with the periodontist, with the implantologist, so you can really split all this information, share all this information. And there is also a possible integration with digital workflow systems. That is very important too. So data collection, again, is the basic principle that we have to follow in order to have all the information, all the data on the face of the patient. We are talking about aesthetic result. We have to start with the face and then to go to the lab, to the lips, to then to label analysis, and then to phonetics. And only after that you can really focus on really the teeth, important, the teeth topic. Okay? So first of all, we need a kind of camera like this. We can obtain even with the iPad. You can use it that very easily, and having a kind of mask using GetUp, and having the chance to really have the same kind of size of your patient in front of you. You use a mask that are surrounding all the face, and you have the chance also to have two levels, vertical and horizontal level, that helps you to really have the same kind of position of the face in front of you in every case. Of course, knowing that the picture is a static moment of a dynamic action, we love to have this kind of videos. Very important for many steps, for the smile, for the sounds, the F sound, the S sound. So it's very useful to combine to the picture also the videos. And then you can judge all the information that you receive from other principles, from other parameters, like smile line of the patient, labial corridor, interincisal line versus medial middle line of the face of the patient, many other stuff. I cannot really describe all this today, but just to give you an idea that, of course, you will be helped by the application itself to really, that guides you in a proper position, in a proper way that allow you to achieve the best result in terms of deciding what to do, what not to do. Because together with the aesthetic parameters, you have to combine also the functional parameters. So the combination of both allow you to achieve this kind of position. So to decide how much you have to lengthen the teeth, how much you have to shorten the teeth, how much you have to put more buccally or more lingually the teeth either, or how much you have to increase the vertical dimension, for example. All these data are inside the GetUp, and you can really learn a lot following these. Of course, you have also 3 colors like yellow, orange, and yellow, red, and green that allow you to understand exactly where you are. And if you are in the right position, the right road, you can follow in this way without any problem. You can really understand if you follow the green line, it means that you are in the right numbers. Right numbers that helps the technician to follow you perfectly, because they can really not invent any kind of differences from the initial case, but just having the chance to follow you guidance, your help, because you have checked your patient from the aesthetic and functional aspect. So you know exactly what is the need of the patient. And the technician will receive all this data, all this information. You don't have to invent, you have to follow what you have checked in your patient. We have also the chance to create a kind of rendering, like in this case, and you see that in this way you can understand, for example, the overbite overjet ratio, that is very important, of course, as you know. You can modify something on the upper length. Look, you can lengthening, shortening, and all the numbers changing on the left side, on the upper 11 and 41. Changing. Why? Because you are moving. You are kind of rendering procedure. You can do what you want. You can preview something that you will then achieve on your restoration, with your restoration. So then you can also press this red button. You can have a kind of ebook behind. Every screenshot has this kind of chance, of possibility. So you can have some explanation what you do about the topic you are talking about. And together with that, we have also the question mark that helps you in order to understand how to use this kind of application. So GetUp is the name. I believe that is something very useful, completely new, not just talking about, the aesthetic parameters, but about both aesthetic and functional parameters. I believe that is the only one that is capable to do that. And finally, dental technician will receive, maybe for the first time in their life, exactly all the information they need to really understand what you have to change in the case they have in front of them. So you can apply all these and follow this information that the clinician gives to you as the dental technician, and having the chance to fix the problem and to change completely the rehabilitation. So that is something that is really important. You can really press the button and the technician in 1 second receive all these picture, videos, all the info that you needed, all the decisions that you have made, and they just have to follow what you decide to change. Length, as I said, buccal lingual position, increase the video, all this stuff. And then also the material that you selected. And then you can go ahead, the next step, with the analog and the fully digital way. So analog, you can use the normal Facebook. Fully digital, you can use any program that you wanted, but you can add volume, you can add length, you can decrease length, as you like it, depending on what you have found in the data collection phase in the treatment plan formulation. But you can go ahead then with the 2 modalities, one traditional, one fully digital. And of course, you have to learn a lot about that. So just in case you need to have more information about it, so go to www.getupfradeani.com. So let me go back to the basics. That is very important, because that's a very normal concept that I believe that is important to remember that. So how to really understand your case, where you start to analyze your case. As I said before, even today, many people are really happy to show the six upper anteriors and to position on the computer the six upper anterior on the frame of the face. I believe that is not so really well integrated in the real life of this patient. Why? Because of course we needed to really combine, as I said, many information. And the first step is not just to show the six anteriors, but to analyze the face of the patient. First of all, the face. Second, the dental-labial aspects and steps, and then the phonetics, and then only after that on teeth and gingiva. So we start with the face of the patient, and we start again with the dental-labial analysis. And we understand, for example, in case like that, in which we have a very low smile line of the patient, that we don't need maybe to do incredible things to realign perfectly the gingiva outline. It's not needed because the patient doesn't see that. Of course, it's completely changing when you have the average smile line, which you have the papillas that are really visible interproximally between one tooth and the other tooth anteriorly, or even worse, if you have the high smile line or the gummy smile line. Of course, you have to do your best in order to fix the problem. That will be not so easy, it will be complicated, but you need to do it because the patient, when he talks, when he shows, or when he smiles, he shows or she shows completely the gingiva outline. So you are forced to do your best in order to fix the problem. But what to say about the dental analysis and the facial analysis? The facial analysis has to see that all the parameter, horizontal and vertical parameter, like bipupillary line, like vertical line, should be really considered as a very important step in order to really harmonize all your work, all the orientation of your rehabilitation to this kind of parameter, vertical and horizontal. Very, very important. And of course, our duty is that to understand since the beginning, look at the patient in front of us, taking picture, looking through the movies, so having the chance at the end to avoid this kind of problem. It means to really finalize your case with a misorientation of the occlusal plane that is not in harmonic relationship with horizontal reference line, like horizon, like lips, like eyes. Exactly, that is very, very important. So that is a big mistake. And of course, the horizontal, the occlusal plane should be parallel to the horizon. That is the ideal situation. Shouldn't be inclined in one side or on the other side, because it starts to have the very miscommunication between the technician and the dentist. Should be very important to really catch this point and having the chance to really send all the info to the dental technician in order to avoid this inclination of the occlusal plane in comparison to the horizon, to the horizontal reference line too. So that's a very important step. And let me show you a very easy clinical case. This young lady coming from Spain, was complaining about the need to create some veneers on the upper and the lower anterior area. And one colleague, one dentist, sent us this lady to do the case with the recommendation to do something for them after having done some orthodontic treatment. So you can see how the inclination of the occlusal plane and also the gingival outline can influence in negative way the overall picture of the patient. That is really slanted, inclined, is not good enough. So what you need to do in this case, we cannot do any ortho again because the patient just finished the orthodontic treatment and the colleague, the other dentist, sent to us after having done the ortho. So I cannot do ortho again. I needed to do some little surgical procedure in order to realign the gingival outline, and then prosthetically, restoratively, we had the chance to also to recreate some better orientation of the incisal plane and the occlusal plane in order to be able to be compared to the horizon or to the horizontal reference line. That is our goal, to really create a kind of harmonic relationship at the end. That happened on the upper jaw, like that. And they happen also on the lower jaw, where we put also an implant on the left cuspid on the lower arch, and we have obtained a similar result also on the lower jaw. So you can appreciate the final outcome. The lady was improving the parallelism between horizontal reference line and the orientation of the occlusal plane, especially the incisal plane, and we obtained nice result that was also maintained over years. After 12 years in service, the patient shows still very nice and harmonic relationship between all the parameters that we have in the face and the lips. Yes, lips, because you have to consider that another very important parameter is that to understand that the dental labial parameters are to be followed. So we start always with the tooth exposure at rest of the upper teeth. Tooth exposure at rest that shows the two central incisors of the upper arch to be the most convex area of the incisal edge, looking the patient frontally. And of course, this convexity of the upper incisal edge will be more or less parallel to the curvature of the lower lip line that is concave. So that is really some harmonic relationship. So tooth exposure at rest, incisal edge convexity, that are the most important step to start with the patient treatment. So let me give you an example in this case. This is Max, he's a patient from Florence, and he was talking, not showing teeth at all. He want to fix the teeth, but I could say, no teeth there. Maybe I need to denture. Maybe not. Look at this. He had actually very bad situation in terms of wear. Attrition was there, and the teeth are very, very short. So that is why when he was talking, he didn't show at all teeth. That's the problem, because that's not a good aesthetic result. You don't show teeth when you smile, when you talk, when you are at rest. So it's very important to understand that is really an empty area that should be filled and occupied by some teeth. But the problem is, where should be? Look, teeth are lost on space, as you could see here. So what to do? Where the teeth should be positioned? Maybe here? Maybe. Maybe are too short, maybe are too long. How to decide? We have not the mimic of the patient. We have not the area of the smiling of the patient moving the lips. That is very complicated. Should be maybe here, or maybe here. So we have to decide where, but not through the picture, not through one picture, not through positioning the picture on the frame of the face in a static moment. You should be really able to do something more. It means some mock-up probably. You have to add volume and of course looking. But how to guide the mock-up, how to guide the technician, how much to increase the length, etc., etc. And of course you have a lot of steps that you have to learn, of course, easily, like the incisal position, from the frontal view, from the lateral view, the two proportion. You know that the central incisor should be, the width of the central incisor of the upper jaw should be 80% of the length of the upper incisors. And then, of course, the tooth exposure at rest, how much you show at rest with the smile line of the patient, the overjet and overbite ratio, so the functional aspect also. And then all these are helping you on achieving a nice final aesthetic diagnosis. And that is very important to achieve this result before deciding where to do it. Starting from the very simple example that we discussed already, it means the two exposure at rest, the two central incisor. If I show to every patient in the world these three drawings, no one will select the right one as the ideal one. Everybody say, no, I don't want this one. But then you give the mirror to their mouth, and most of the time, the people over 50, over 60 years old, they show 90% of cases only the lowers. And that is easy to understand. That is, of course, something of aging effect. So our rehabilitation should take into consideration the fact that at the end, the tooth exposure at rest should show some length, even not 3 or 4 millimeters, maybe 1 millimeter only. So that is a big Brundo study that shows you that depending on the sex and the age of the patient, you can show at the end between 1 to 5 millimeters. Of course, 5 millimeters in young ladies, 1 millimeter maybe the old man. Okay, that is the range that should be considered before starting to finalize the case. And of course, you should start as a starting point of your evaluation of the position of the teeth from this parameter. So the incisal edge with the tooth exposed at rest of the two central incisor, as we said already, and with the convexity of the incisal edge of the upper teeth. In our case, Max, our patient from Florence, showed nothing, like in the right side, but even the left side is not good because showing just the lower arch. It is not the way that you want to achieve this result. So when you have to restore teeth, when you have to restore patient, you should be able at this point to know that the more you get older, more you should lower than the upper, and then vice versa, of course. So that is something that you have to consider, not just because we have the wear of these teeth, but also because we have some tonicity of the soft tissue around, like lips, like cheeks, that shows a kind of decadency. It means that we become less tonic, and then decrease the height, and you don't see anymore the upper teeth in this case. So what to say? At this point, you can use the mock-up when you have to add length. We have done this kind of solution, for example, on the central incisor, on the upper jaw on the right side, and you see that we can show something at this point, different than the left side on the upper. So we know that if you add also the other side on the left side, we have some visibility, maybe 1.5. She's a lady on the 50s, and that is what we need at the end. And at the end, we achieve this result, covering with the upper teeth, the lower teeth that are also brownish. Actually, in this case, we change completely the smile line of the patient. The convexity of the incisal edge is something that the patient likes a lot. And that helps also you on obtaining also some functional optimization, remembering that we need normally to achieve this kind of anterior guidance, cuspid and incisal guidance, with the anterior in contact when they move upper frontally and laterally, and you avoid any kind of interferences on the back area when you move this anterior area to the cuspid guidance and anterior guidance and the incisal guidance, as is shown in this picture that doesn't touch any posterior teeth. So with the aging, one important step is also that we normally have a flat incisal edge more and more, because the wear, most of the cases are really represented by that, with a flat incisal edge, or in some cases also with the reverse incisal edge. And that is what we need to change it. Like in this case, we have quite a flat incisal edge, as you see here. As you can see, there is a discrepancy between the incisal edge on the left screen, as you see, and the lower lip line. Look, the lower lip line is concave. So we should obtain a kind of harmonic relationship between this incisal edge that is too flat, restoring them in a convex way, and having the chance then to follow the lower lip line. We did that with the mock-up, like in this case, as you could see here. We printed this mock-up in the patient, following the work-up that we made already with dental technician. We remove the mock-up. It's still not to refine this case, but just to understand how you can improve it. Easy. That is an additional volume that can be done. Today we do credible refined mock-up. That is nice, but of course what you need mostly is to have the content inside. How much you have to increase it. We study the case, and then you decide it, and then you try. If the try is okay, you can confirm to the final work. That is more or less what you do. As you know, mock-up is a reversible step. It means that you can really say, I would like to go ahead, or you don't want to go ahead because you don't like it, so you can remove in 5 minutes, friends as ever. No problem at all. But it's a preview without touching the teeth is a great, great, great tool. And in this way, you can show the patient the improvement. The patient will be happy, and you can really at this point share and go through the final step, to the final work. So having tested with the mock-up, tested and proved that is the position we want to achieve, at this point you can copy to the final work. So that's the beginning, and that's the final result with a nice final integration from the aesthetic, functional, and biological point of view. So together with the aesthetic parameters, of course, in the data collection, you should absolutely add also the functional parameters. Remember, aesthetic never come alone, but together function all the time. So we need to understand that, especially in the case that we are extended case, like 6 upper anteriors, or maybe the entire arches, 1 or 2 arches, we need to really follow some guidelines. And I believe, even though it's maybe generic right now to talk about that, but anyway, I should say we need a crucial stability of your work. The crucial stability on posteriors means, really identical moment of the touching on posteriors, very marked contact on posterior areas, equal intensity, okay, at the same timing, and it's very important to obtain the stability. And normally is obtained in centric relation position, but that's another story. Then, of course, you should have a synchronized punctiform point, equal intensity as I said, and if posteriorly we have a marked contact, anteriorly we have a light contact, not fremitus should be understood here. You should really avoid fremitus, you should have a nice light contact there. And then you have an anterior guidance, as we said already, to really avoid any posterior interferences during excursive movements of the anterior area. So anterior guidance, it means cuspid and incisal guidance, should avoid any contact on posterior, any interferences, to really have the muscle less involved. And at this point, we discussed already about this, we described that. So YCR, many steps many steps should have been explained on that, but the most important part is the reproducibility of the position of the mandible. That is what we like a lot, what we like to have no case that are not just a single restoration, but maybe 6 upper anteriors, or maybe the 1 arch or 2 arches. So we need really to have this kind of repeatability of the position, and also decrease of the muscle intensity. And of course, talking about function, you don't have to forget that the ratio between overjet and overbite should be, of course, the best one. We cannot just refer to numbers. Normally, average is 2-3 mm overjet, 2-3 mm overbite are considered more or less the ideal one. And most of the time, they are more or less ideal. But what I believe that is very important is understand that if you have 10 degrees of change on the angle of disclusion, there is a 35 change in the force applied. So if you are flatter guidance, you have a less muscle involvement, less strength, less probability to have a restoration that will be fractured or chipped. So it's very important. Of course, you can flatten the incisal edge, but not achieving the result to touch on posteriors during exclusive movements. Again, remain, of course, important step that we have to keep the anterior guidance that exclude the posterior teeth, not contact the posterior teeth during exclusive movements. But at the same time, if you're more flat and not so steep, that will be an improvement of muscle involvement that will be less and less. That's very important. So we need more overjet in this case. If you start like that, we should arrive to that situation orthodontically, prosthetically, having increased the vertical dimension. So you need more overjet, not having so close relationship between upper and the lower like in the left side. Overjet increase is a must in most of our cases, but again, not having the chance then to create interferences on posterior area, but just having more overjet is still excluding the posterior area. So anterior guidance stiffness had to be reduced as we have described already. And again, at this point, we have obtained incisal edge position that is perfectly achieved, looking the patient frontally and looking the patient laterally. The both situations, the two visions, will be very important to decide where the incisal edge should be. And remember, the incisal edge position represents the starting point of your treatment plan when you are doing pros, when you are doing restorative. I'm not talking about one tooth, of course, but having the chance to have like 6 upper anteriors and 6 lower anteriors either. So the starting step of the prosthodontic implant starts from that. Of course, then if you have eye-smile line, it's very important to have the gingival outline that is perfect. Align right and left side. That's great. But sometimes also you have to decide where to add length when they have short teeth. Normally you lengthen the incisal edge, but sometimes you need to lengthen also the cervical area to obtain the best result. Or sometimes it's like a combination of both. So it's very important. I believe that it's nice to look at this. This is the case that was happened to see and to be treated more than 10 years ago, 12 years ago. And to have the nice final outcome in terms of proportion and length, you should increase the length so much that we divided maybe up cervically and incisally. But let me best check with you how to start our analysis, how to start our treatment plan. Look at the left side. You have the very minimal visibility of the upper anterior. The lady is on the 20s, very young. And normally, the young lady shows between 3 to 4 millimeters of the incisal edge of the two central incisor at rest, just doing nothing, at rest only. So, that is not showing at all. 0.5 millimeter, ridiculous. So we need that we have to lengthen the teeth. The teeth are long, just 5.5 millimeter, very short. We have added 2 millimeter, 2.5, and now we have a 3 millimeter of visibility. That is nice. From 5.5 millimeter length, now we have 8 millimeter, but still not 10.5, 11 as normal. Normally central incisor length is between 10.5, 11 millimeters. We have just 8 millimeters. So at this point, we have done this mock-up very rapidly, not refined, just to have an idea how can obtain the lengthening of this teeth, how much should be. And to define the incisal position, we have to evaluate all the aesthetic and functional parameters. Aesthetically, first of all, tooth exposed at rest, as I said, was 0.5. We have to add it, and we have increased with mock-up, the direct mock-up. And then incisal edge curvature. Thanks to this elongation of the two central incisors, we elongate all the incisal edge, become convex. Look in the incisor profile from the lateral view. And then look in the smile line. Is showing completely or not? That's important to have a nice proportion of the central incisor if you show completely this teeth. If you don't show, you don't care. You can also avoid to do all these things. But if you show like this case, you need, of course, to obtain your maximum result. So the smile line is very important to be defined at the beginning. And then to optimize tooth length and proportion. You cannot avoid to optimize the level if you show completely the teeth. And then you have the functional parameters. Functional parameters are overjet over bite. We have discussed already. You have to look clinically. You can have the chance to say, yes, 2-3 millimeter overjet, 2-3 millimeter over bite is the ideal. But then you have to taste. You have to test on the patient mouth. Let them move the mandible in front, laterally, and you can understand. Sometimes you are very easily moving right and left, but some other times you are not so easily moving the mandible. So you have to touch a little bit the occlusion until you have the best, fluidity of the incisal edge the anterior guidance, cuspid and incisal guidance. That's very, very important to obtain this result. And then, of course, you can decide your overjet or overbite value according to the clinical test. That's very important. So numbers is okay, generally speaking, 2-3 millimeter of a value, but then you have to test with a clinical test in the patient mouth, having always the rule in your head that you have to avoid any contact on posterior area during excursive movement, but still having the chance to move the mandible very, very easily with no muscle involvement. Excessive that. And then you have phonetic evaluation with S and F sound. It's a long story. I cannot tell you all these steps together today, but actually have the chance to at least consider the old aesthetic and functional parameters, plus some phonetic one. So the decision that was made at the end, rehabilitation of the upper arch with CR position, video increase of a couple of millimeters. Incisor was lengthened 2.5 millimeter incisally, as you have seen before with the mock-up, and 3 millimeter apically. We need to do some surgical cross-lengthening procedure. So minimal preparations. We have to enlarge the arch, gaining automatically some space for your restoration. So prepare less because you have to go more frontally. We want more visibility of the entire arch. So move the teeth backly to increase the teeth width. And that is what we obtain in this case. At this point, we have increased 2.5 millimeter incisally and 3 millimeter cervical. That was our decision. And we see what happened next. So we have to anticipate the final outcome and to obtain this kind of result. 2.5 incisally, 3 millimeters cervically, that we designed by myself to the surgeon. You see now the length that was added incisally and the length that you want to add cervically with the surgical cross-lengthening procedure that was done by Stefano Gori. This is our periodontist and implantologist that work in our office too. And that is what we obtained at the end. The ceramist was Giancarlo Balducci, my technician for 4 years, and unfortunately he just passed away a few days ago. But great work, great job, great technician, great man. So we just extract one tooth on the upper side, right side, bicuspid was retracted, but we have the chance to fix the problem everywhere, big decays all around. We have the chance to avoid any devitalization thanks to the increase of vertical dimension that was achieved in this way, the chance to avoid any kind of devitalizing teeth. So, rest position at the beginning, rest position at the end, approximately 3 millimeters, we increased 2.5 millimeters at the end. 12 years later, we are still in the position that we believe that are the right position, with a nice aesthetic result, with a nice aesthetic harmonic relationship with the lower lip line in terms of incisal edge convexity and lower lip line that is concave. And that is the result that we obtained many years later, and with the satisfaction of the lady that was very shy at the beginning, but then it was so improving the self-confidence so much that then she started to play with the camera, to play with us, and showing the best result and the possibility to really optimize the result of your work and to satisfy your patient. So just to go back just to say, okay, we have seen how to go ahead traditionally and how to go ahead also digitally with the innovation on the 2D application like GetUp. So you can use both. In some way you can use the new tool like the Frederian Education app, the called GetUp, or you can use laboratory chart. You can use a piece of paper and just write there some notes. The most important step is, please don't receive the case and start to grind teeth. Think about what you should analyze in terms of aesthetic and functional analysis. Only after that, when you have collected all the data, you can formulate the right treatment plan. Once you have done that, at this point, you can start to grind teeth and to bond restoration, not before. Thank you for staying with me for this lecture.